Hello, good evening, everyone. Welcome to another session. We're going to see syndromes in surgery, second part today. So, the first one we're going to look at is Gerstmann syndrome. So, basically, why is this Gerstmann syndrome happening? You know that brain tumors is one of the common conditions we encounter. So, whenever there is a tumor in parietal lobe, especially the dominant hemisphere, so whenever there is a tumor in parietal lobe, it can lead to a group of symptoms which is called Gerstmann syndrome. So, you just need to understand what are all the normal functions where this particular location within the parietal lobe is contributing for. It means that, for example, normally this area is important for finger agnosia. Means you have to identify which finger, which one is which finger. So this is called identification. So if there is any disturbance in that particular thing, that is called finger agnosia. What is it called? Finger agnosia, right? Normally, this area is also responsible for calculations. Now, because of this tumor sitting in this particular area in the parietal lobe, it will lead to a condition called acalculia. Okay, and the patient will get some confusion between right and left. So, this is called right and left disorientation. Also, patient will not be able to write properly. He'll not be able to follow the writing spontaneously. What is this called? Agraphia. Okay. So these are the four important features in case of Gerstmann syndrome. It is because of a tumor in which lobe? Parietal lobe. Where exactly? Usually in the dominant hemisphere. Okay. Right. Next, we are going to see Horner syndrome. Again, it's a very important topic. You know that basically Horner syndrome is of two types. One is congenital, another one is acquired. So usually one of the common scenarios when you will see Horner syndrome is that whenever you have any apical lung tumor and it will go and compress or infiltrate the sympathetic chain supplying to the head and neck. Otherwise, sometimes what happens whenever there is a thyroid malignancy, it can expand, it can in an advanced stage, it can grow posterolaterally and it will compress or infiltrate the sympathetic chain which is present posterior to your carotid sheath. So, in such condition also you can develop Horner syndrome. So, what are all the different things we are having in Horner syndrome? So, the first one is heterochromia iridis. Just analyze the name. Hetero means different color, chromia color. So, iridae. So, it means that both iridae will be in different colors, and it is usually seen in congenital Horner syndrome. Now, the second point is inferior eyelid eversion. So normally this inferior eyelid tarsal muscle, it is supplied by sympathetic system. Now because of the damage of sympathetic system here, you are having that paralysis of inferior tarsal muscle, and now the patient is going to develop something called inferior eyelid eversion. So that is the concept, right? Next, so it is the basic pathogenesis mechanism that we are having sympathetic supply damage. Where exactly? Which is supplying to your head and neck. Okay, right. Next point is anhydrosis. N means absence, hydrosis means sweating. Where exactly? Absence of sweating on the affected side of the face. For example, let's say a patient has got right side apical lung tumor. So what happens? Right side sympathetic system which is supplying to the head and neck will be infiltrated. Then patient will develop absence of sweating on the right side. That is called anhydrosis. Now meiosis, it means nothing but your pupillary constriction. So why is there pupillary constriction? Normally sympathetic system is responsible for pupillary dilatation. Whenever there is Horner syndrome, there will be dominant action of the counter muscles. That is nothing but your pupillary constrictors. That is why there will be pupillary constriction happening. Right? Next is very important point, partial ptosis. We will see why partial, why not complete. And next one is loss of cerebrospinal reflex. The last one is relative anophthalmos. Okay. Now, what is loss of cerebrospinal reflex? See, basically, your sympathetic stimulus will dilate the ipsilateral pupil. Now, when someone is pinching on the nape of the neck, it is nothing but a sympathetic stimulus. Normally, what should happen? Ipsilateral pupil should get dilated. But in Horner syndrome, whenever someone is pinching at the nape of the neck, there will not be ipsilateral pupillary dilatation. So this response of ipsilateral pupillary dilatation to the sympathetic stimulus is called ciliospinal reflex. But in Horner syndrome, it is lost. Right? Next, partial ptosis. Why only partial ptosis? Why not complete ptosis? So here you should understand one concept. Normally, for the elevation of your eyelids, upper eyelids especially, you have got levator palpebrae superioris muscle, and this has got two parts. One is voluntary part, second one is involuntary part. So this involuntary part of levator palpebrae superioris is called Muller's muscle. Okay, this is called Muller's muscle. Now, what you need to understand is that this voluntary part of LPS is supplied by third cranial nerve, nothing but your oculomotor nerve, whereas this Muller's muscle is supplied by sympathetic chain. Sympathetic chain. Now, in Horner syndrome, what is damaged? Only sympathetic system is damaged, whereas third cranial nerve is still intact. That is why there is only partial ptosis, but not complete ptosis. Okay, right? So these are all the things you should remember in Horner syndrome. You can just simply remember with a mnemonic: high sample, high sample, right? So this is about Horner syndrome. Now, next one. Klippel Trenaunay syndrome. So you need to remember this is in relation to very important condition called varicose veins. We usually clinically see in case of varicose veins. So what will be happening there because of the venous malformation, arterial venous malformation? There will be cutaneous nevus. So as you can see from the picture, there will be cutaneous nevus. Then persistent vestigial veins with varicose veins, and also soft tissue and bone hypertrophy will be there. So what happens whenever you are having soft tissue and bone hypertrophy? It will lead to limb lengthening. It means that whatever the side the limb is affected, that side limb will be longer than the normal limb. So as you can see from the picture, this particular limb is longer. It is more in length when compared to the normal limb. Okay. And you should remember it is a mesodermal condition and it is non-familial condition. Okay. This is in relation to varicose veins. The syndrome is Klippel-Trenaunay syndrome. Right. Next. Very important, Lery syndrome, coming to vascular system. So you know that at the level of L3 by L4 vertebral level, your abdominal aorta will be bifurcated to something called two common iliac arteries. And again, they will be divided into internal iliac artery and external iliac artery. Let's say, for example, whenever there is a saddle thrombus sitting at the junction or at the bifurcation of your abdominal aorta, what happens then? So, you know that basically these gluteus muscles are supplied by obviously one of the branches from your either internal iliac or external iliac. So you need to remember there will be how does the patient present? There will be bilateral buttock pain, and of course pudendal artery is one of the important branches from your internal iliac arteries. So the blood supply to the external genitalia, especially in penis, also will be decreased. That is why patient will be having impotence. Okay, and because there is an obstruction within the aorto common iliac level, there will be absent bilateral femoral pulses. So these three symptoms are grouped together called as Lerish syndrome. Okay, right. Next one, Loeffler syndrome. It is just one of the advanced stages of your ascariasis. So where the larval stage will be affecting the pulmonary system. Okay, so what will it cause? It will cause patchy consolidation, especially in peripheral areas. What does it cause? Patchy consolidation at peripheral areas. At periphery. So how does the patient present clinically? So there will be fever, there will be dry cough because of the respiratory system affected, and there will be chest pain and dyspnea. So this Loeffler syndrome is also called simple pulmonary eosinophilia. simple pulmonary eosinophilia. Eosinophilia, as you can expect, it is because of parasitic infestation. Okay, this is about Loeffler syndrome. Right. Next one, very important. It is called Lynch syndrome. It is previously called HNPCC, hereditary non-polyposis colorectal cancer. Okay, right. So mainly it is nothing but one of the most common forms of hereditary colorectal cancer. Okay, so why is it happening basically? It is because of a inherited mutation in DNA mismatch repair genes. Usually, even though we are saying hereditary non-polyposis, but eventually what is happening is that it will cause something called colon polyps, and it is a predisposing factor for your colon cancer, colorectal cancer. Okay, so this is about Lynch syndrome. Okay, right. Next one is Mallory-Weiss syndrome. Very important. So we should remember it is nothing but you can simply remember from the first letter M for Mallory-Weiss, M for mucosal tear. Where exactly it is happening? At GE junction. Why is it happening? Basically, as you can see, it is a longitudinal mucosal tear near the GE junction. And this is the endoscopic picture. As you can see, this is the longitudinal mucosal tear. Okay. Now, why is it happening? Whenever a patient is trying to vomit and unfortunately at the same time your lower esophageal sphincter, normally it should relax, but whenever this lower esophageal sphincter is closed but still there is forceful retching against this closed lower esophageal sphincter, so there will be mucosal tear happening at the GE junction. Okay, that leads to Mallory-Weiss syndrome, right? So how will you diagnose it? Obviously, you have to go for endoscopy. Usually, 90 to 95% of the cases, it is self-resolving. But if it is not resolving by its own, we will go for endoscopic coagulation. Okay, what will we do? So we will go for endoscopic coagulation. Okay, this is about Mallory-Weiss syndrome. Now, the other thing you should remember in relation to Mallory-Weiss syndrome is that, see, normally when a patient is vomiting, both upper esophageal sphincter as well as lower esophageal sphincter should be relaxed. But whenever a patient is vomiting, unfortunately at the same time, if upper esophageal sphincter or glottis is not open, what happens? There can be full thickness mucosal, I mean, all the layers of esophagus will be perforated. So that will lead to a condition called Boyer-Haave syndrome. Okay, so Boer-Hand syndrome is nothing but a complete full thickness perforation. Whereas if it is happening against closed lower esophageal sphincter, it will lead to what is called Mallory-Weiss tear. Okay, so this is the main difference between Mallory-Weiss tear. This is the main difference between Boer-Haave syndrome and Mallory-Weiss tear. Okay, right. Coming to the next one, May-Turner syndrome. This is also called iliac vein compression syndrome. So just remember iliac vein compression syndrome. So which iliac vein is getting compressed here? Left common iliac vein. Why? See, in few individuals, there is one abnormal anatomical configuration where your right, so this is the right common iliac artery. So this right common iliac artery is compressing the left side common iliac vein. So you can see here in the picture. So left common iliac vein is being compressed by right common iliac artery. So what happens there? There will be membranous occlusion of this left common iliac vein. So subsequently, patient can develop either varicose veins, either in the thigh or in like left lower limb, basically. Okay. So because of the compression of this left common iliac vein, there will be congestion of the blood, congestion of the lower limb in on left side. Okay. So this is called May-Turner syndrome, which is also called iliac vein compression syndrome. Okay. Right. Then, very important, men syndromes. So, you know, multiple endocrine neoplasia. So, men syndromes are of four types: men 1, men 2A, men 2B, which is also called 3, then men 4. So, men 1 is also called, please remember, it is Wermer syndrome, not Werner. Werner is nothing but it is premature aging because of progeria, basically. Okay, that is Werner syndrome. This is Werner syndrome. You have another important classification called modified. Sorry, you have another important classification called modified Werner classification. Where will you come across this modified Werner classification? In case of thyroid ophthalmopathy. That is the grading system to categorize the features in thyroid ophthalmopathy, Graves ophthalmopathy. Okay. Now this is called Men1 is also called Wermer syndrome. Okay. Now you can remember with the help of mnemonic Pa Pa P. Okay. Pa Pa P. So, pancreatic endocrine tumors, parathyroid, and pituitary adenoma. Okay, right. This is in men 1. Now, men 2A is also called Sippel syndrome. What are all the different tumors you are having here? Medullary thyroid cancer, parathyroid adenoma, megacolon, pheochromocytoma. Okay, right. This megacolon is mainly because of RET, right? Oncogene mutation. Okay, right. Now, coming to men 2B, which is also called men 3. This is otherwise called Wagenman-Frobo syndrome. Now, just remember this 3, if you just reverse the direction in a little bit, just change the direction. So, 3 is nothing but M. So, please see all the component tumors are or component features are with M. So the first one is medullary thyroid cancer. You have medullated corneal nerve fibers, then mucosal neuromas of the tongue or mucosa, then Marfanoid syndrome. Last one is megacolon. Okay, so these are all the different components of your men 2B, which is also called men 3. Now the last one is your men 4. Okay, so it is nothing but same as MEN1, but additionally you are having adrenal, renal, and reproductive organ tumors. Okay, these are all the different men syndromes. Okay, now next one is Ogilvie syndrome. This is otherwise called acute colonic pseudo obstruction. Why pseudo obstruction? Basically, this obstruction is not due to because of any mechanical cause. Then why is it happening? It is because of where you will see this condition is that old people or bedridden or after surgery where there is problem with the autonomic control. So what will happen, there will be acute massive dilatation of the colon with obstructive symptoms, but please remember there is no mechanical obstruction here. Okay, now what is the main cause for this? It is because of the malfunction of the autonomic control. So what should you do? Obviously, you should go for colonic decompression. How will you decompress the colon? You can try by giving a drug called injection neostigmine. So what is the name of the regimen? Catch pole regimen. Okay. So what are you trying to give? Injection neostigmine. Why neostigmine? So neostigmine is nothing but basically it is a acetylcholinesterase inhibitor. Okay, so by inhibiting the acetylcholinesterase, this drug is providing more amount of acetylcholine, which will be available at the synapse. You know that acetylcholine is very short acting. So by inhibiting the acetylcholinesterase enzyme, acetylcholine levels are increased at the synapse so that it will normalize the peristaltic activity of colon. So the decompression will be happening, right? This is about Ogilvie's syndrome. Thank you.